So welcome, my name is Catherine. I am the Regional Coordinator for Scotland and Northern Ireland with Leukaemia Care. Today we are joined by Lisa, who's going to be talking a bit about menopause and women's health in relation to a blood cancer diagnosis. We are going to be following on this webinar with a national support group as well. I will share a little bit about that in slides at the end, just a little note for your diary. That will be more of a kind of Zoom face-to-face type support, so you can peer support with each other. We can ask some questions towards Lisa and follow on from any discussions that we've had today. We're hoping to be joined by someone from Look Good Feel Better today, but unfortunately she's not able to be with us. I will still share a little bit about what supports they have, and they're going to join us at the support group as well. So that'll be talking a little bit about self-esteem and building confidence after treatment, or just in general alongside a diagnosis. So I will pass over to Lisa just to introduce herself. You can tell us a little bit about the work that you do, Lisa, and then Lisa's going to do a bit of a talk. We will have the opportunity after the talk to address any questions that come in through the chat box. So do feel free to pop your questions in there as we go along, or if you're joining us from Facebook, you can pop your questions in the comments and we'll pick them up from there as well. That's about us. Lisa, I'll pass over to you. Thank you for joining us. We were very lucky to have you previously at our women's support group. We got such good feedback from Lisa's talk that we felt it would work really well in a webinar setting. This way it's recorded, you can go back and watch it if you want to, or for people that can't attend on the day, they'll be able to access that same information. So over to you, Lisa.
Oh, thank you so much, Catherine. It's lovely. Welcome everybody that's joining us today. I am a centre head of Maggie's in Cambridge, but have a clinical background of 26 years as a consultant radiographer in gynae oncology, with a real passion around not only late effects of treatment, but also the impact that a treatment-induced menopause or a menopause that occurs during treatment, how that's managed, how the information is relayed from healthcare professionals. And I think at a time when you have a cancer diagnosis, often the priority, as it should be, is good clinical care, but with less of a focus on the sort of the rehabilitation and quality of life after. So we feel in a privileged position to be able to share some of the work that we're doing. And not only are we trying to help support people experience treatment-induced menopause, but also raise the profile of that within organisations and at even parliamentary level, where we can maybe make a difference to how this is perceived within healthcare. So as Catherine said, I'm very happy for you to put questions in the chat. I'm also very happy to be interrupted. So if there's an urgent question that comes through on a specific topic that I'm talking about, then Catherine can interrupt me and we can try and just explore that. I will bring to the webinar some of the experiences that I've had with the workshops that I've done interactively, but equally, you know, we're here to help support you and answer your questions. And I think probably after the webinar as well, Catherine will be able to share my direct contact with. So if there's anything specific that you'd like to follow up on, then I'm very happy to be involved with that. And that can be virtual if you're not local to where I'm based. So I'm going to go on and share my screen so that hopefully that's all come up. Give me a nod, Catherine, if you can see that. Brilliant. Okay, so I've done a little bit of around the introductions, but what I'm going to be focusing on in the next sort of 20 minutes, 25 minutes is what is the menopause? What does it look like? But also comparing a little bit around a naturally occurring menopause or perimenopause in relation to a treatment-induced menopause, and there are some significant differences. I think it's important we think about the physical, the sexual, the psychological integration of all of the elements of treatment, a cancer diagnosis, and how that manifests itself in the experience that you have when going through a menopause. What's important, I think, is to think about what the current evidence base is around how you manage those symptoms, and that can either be through a medical intervention or a non-medical intervention. So we'll be looking at all of the different options. And one of the things that I think is really important for me is to enable you to have a really good knowledge of the current evidence base, so that you can open up conversations with your GP or your healthcare providers around that informed discussion, informed consent to what treatment is right for you. The other things I'm going to be focusing on are probably the things that are less visible in a menopause. So that's things around bone health, heart health. And actually, it's quite a lot you potentially can be doing within your own lifestyle trajectory that will make a difference to the long-term impact of some of those less known about challenges following menopause. And then just focusing a little bit on sexual health as well, very rarely spoken about within a clinical setting, but something that clearly has a huge impact, huge impact on quality of life following treatment. So I'm just going to put these up for you now. These are some of the symptoms and changes that I hear on a daily basis, and certainly within the workshops that we run within Maggie's. One of the most common reported symptoms, hot flushes, night sweats. That can lead to sleep disturbance, obviously a change in menstruation, and depending on what type of chemo you've had and what age you are when you have your treatment will depend on whether your periods return or they don't. Low mood, anxiety, very well reported within menopause, very well reported within a cancer diagnosis. So add the two together and clearly that's we can see sort of a multifaceted impact of those two major life-changing events. Poor concentration, often described as brain fog. We're certainly going to have a focus on that. I think brain fog is a fairly challenging title for that cognitive change, and there's been lots of research and lots of papers produced and published around the real cognitive change that happens on the back of menopause, but also on the back of chemotherapy. So again, we've got these two elements coming together that will exacerbate the impact of that cognitive change. Headaches, muscle, joint pain, and again, you know, we see that with chemotherapy. Weight gain is often mentioned when going into menopause. I often see it more as a weight redistribution. People will often say, actually, I'm getting on the scales, I weigh the same, but when I can't get into my normal size clothes, I need to go up a dress size. So it's that weight redistribution that often people notice. I'm going to focus a little bit as well on the urogenital changes, so vagina and bladder. Again, have a huge impact on long-term quality of life. And the vaginal changes and bladder changes actually can be progressive. So often people will present with those changes many years maybe after they've been discharged from their oncology teams, and therefore there may not be the connection that this is something that may be related to a treatment or an induced menopause. I'm going to touch on libido. We're not just talking about female hormones here, but we also have testosterone circulating, so our androgens, and they're responsible for our libido and our get up and go, our umph in life. So clearly that may have an impact on interest in intercourse or intimacy. All of the vaginal changes can lead to discomfort with penetration. So again, I'm just going to talk through some of the opportunities and options for you to follow up on that and what may be helpful in reducing those changes. So that's all really important, but equally important is again, degenerative changes that can happen over a long period of time. So that's thinking about your bone health and heart disease, and then just the general aging. So I'm going to be touching on all of those and just looking at what you can be doing to optimize your health within a treatment-induced menopause. So I'm going to start with hot flushes. And Catherine, can I just ask, how long have I got?
We have this down for about an hour, but
Okay.
as long as you need, Lisa, feel free to go into as much detail as you'd like to.
Okay, yeah, I want to leave enough time for any of you who want to sort of post in questions, so I'll bear that in mind. Okay, so we know that hot flushes, night sweats are probably the most commonly reported symptom peri and postmenopausal, and 75% of people will notice changes, and of those 75%, 50% will find them troublesome. So that's actually impacting on their quality of life. And the latest data is that up to 10% of women outside of an oncology setting, but who have menopausal symptoms, will consider giving up their career. So that's massive. That just demonstrates the impact those hot flushes and night sweats can have. I think it's really helpful just to understand, what is a hot flush? How does it work? Why does it feel like it feels? So basically, when our core temperature rises, we have an automatic response where our blood vessels dilate, they get bigger. And what that enables to happen is our blood to get closer to the skin's surface, and therefore the heat from our bodies can be transferred into the environment. But with that increase in volume, if you like, or the dilation of the blood vessels, our heart has to work harder. So often what people will describe when they're having a hot flush is almost, I feel like I'm having a panic attack. I feel really anxious. And I'm sure, I would imagine some of you on the call tonight actually have experienced that and can associate with those sorts of feelings. And if you think about our brains and how they work, when we go into our fright and flight mode, we're stepping off a curb and a bus is coming, and suddenly we feel that adrenaline rush, our hearts beat, we feel hot, and it's our brains preparing our body to react to something that is really dangerous. Conversely, when you get a hot flush, our hearts beating quicker, we feel hot, we may feel a little bit of that knot in the stomach, feeling a bit sick, and then our brain is saying, oh, this is absolutely terrible, something awful is about to happen, and therefore it's evoking that anxiety and that stress reaction to the physical changes in the body to cool it down. So I think that's helpful just to understand, as is this next slide, where we look at how does the mechanism of a hot flush work. What we know is that we all have this thermoneutral zone. So on this top bar, you can see there's a change in body temperature, quite a significant change here, but there's no sweating because we're really hot, or shivering because we're really cold. We're able to compensate for that change in temperature. What we see here is when this zone narrows, you can see that the same change in temperature or fluctuation in temperature, when it goes up to the top, we're into a zone where we're actually being symptomatic, but equally, the same decrease in temperature will result in shivering and feeling really cold. And often people will describe that extreme change from being really hot, really cold. Now, we know that estrogen is responsible for narrowing that zone, and unless you can take HRT, or you don't wish to take HRT, there's nothing we can do about the impact of that narrowing change from the estrogen. However, what we also know is that there are other factors that can narrow that zone. So things like stress, anxiety, worry, rushing around, being busy, all of those things can narrow it, along with the external factors like caffeine and alcohol. So I often quote, I got a very good friend, we'd go out for a glass of wine, and invariably within 5 minutes she's gone really flushed, she's really hot, she's taken a cardigan off, and at that point she was in her 30s, so she clearly wasn't peri or postmenopausal. But it just demonstrates the fact that those external factors can make a big difference to how much that zone narrows and how impactful those hot flushes are. And one of the reasons I like to show that slide is because when we talk about some of the non-medical interventions to help with hot flushes, and if I'm talking about CBT, if I'm talking about acupuncture, people will say, oh, what are you saying, my hot flushes are all in my mind and I'm responsible for them happening? Absolutely not. But what we know is that CBT, acupuncture, clinical hypnotherapy all have a strong evidence base behind them in scientific journals that they reduce the intensity and number of hot flushes. So in fact, the reason being, you're taking out two of those potential factors that might be making them worse. And it was interesting, I had a lady, I've just literally come out of a menopause workshop for Maggie's, and I had a lady this afternoon who she's done 2 sessions of acupuncture with us. The first session she went in really anxious, not knowing what to expect, a little bit fearful of needles, and didn't notice any difference. She did her second session yesterday and she's not had a hot flush since. So it was a really interesting observation, and for her to share that with people who potentially are in a similar situation. And I've put diet there. Again, the Mediterranean diet, so a good balanced, lower amounts of red meat, more highly weighted towards fruit and vegetables, clearly has been shown to have an impact. Now, I've put a little bit in on alternative therapy, and I'm sure some of you may have heard of sort of that generic message outside of oncology that herbal and non-regulated supplements may be helpful. My issue is, within oncology, we know these impact on how some types of drugs are absorbed within our bodies, but also can cause liver toxicity. So if you've had chemotherapy, which is broken down by the liver, clearly we don't want to be exposing you to unregulated drugs, herbal remedies that might actually compromise your long-term well-being. So I would always explore those with caution. If you're really keen to explore alternatives, then I think one that you can think about safe is oil of evening primrose. It doesn't have any evidence around the efficacy in hot flushes, but anecdotally people have told me they feel better on it. And also there is an evidence base that it helps with breast tenderness. So if you're someone that experiences a lot of breast changes, then that might be something to try, and it's certainly not contraindicated, so that's absolutely safe to take. Okay, so often when I'm running workshops, we have a mixture of people and diagnoses, or people coming with different diagnoses. And actually, if someone is able to take HRT and they're under the age of 60, it certainly is worth a conversation around actually, is this better? And as we go through today's session, you'll see that there are lots of other implications of being low on hormone levels. So it's that risk benefit conundrum that is very definitely worth having a conversation with. I've occasionally worked with sort of patients who've had a sarcoma cancer in their 20s, so they are absolutely eligible for HRT. But in the midst of a young person having a cancer diagnosis, the discussion around long-term health and the benefits of HRT have been lost. And often these people present with their hormonal compromise symptoms being worse than their chemotherapy. So there's a real opportunity, I think, for us to be able to empower people to go and have those conversations with their hematologists, oncologists. So the non-hormonal medication that we can be thinking about, there is only one licensed drug in the UK for hot flushes, and that's clonidine. And actually, we never use it. The efficacy on sleep is absolutely, it's just non-tolerable. I've never met anyone who's been able to take clonidine and it not impact hugely on their quality of sleep. However, there are other drugs that we do absolutely know have a benefit on hot flushes and are licensed for other changes that could be related to the menopause. So oxybutynin is a really great drug for managing bladder changes, so overactive bladder, urinary frequency, urgency, but equally has a really good impact on hot flushes. So if you're someone who's experiencing both of those symptoms, then clearly that drug would be a real pull to maybe try and see if it helps. And this is where you need to be seen as a holistically, and not just as someone presenting maybe with some bladder changes and someone who has hot flushes. It has to be very joined up. The antidepressants have been shown to have really positive impacts on hot flushes, and the drug that we tend to go for is venlafaxine. I do just put those other two up there that often people may be on before they have the cancer diagnosis, but again can have some interaction on the absorption of some types of drugs. And then finally, at the moment, the other group of drugs that we use are those that we use for nerve pain, so gabapentin, pregabalin. They often can have a really positive effect on hot flushes. All of the above do carry side effects. So again, it is that balance between risk benefit, which again, having that conversation and you being informed and being able to go and have a conversation with your healthcare providers is really important. I work very closely with a GP who, like myself, we work in menopause, and she managed to get to the last menopause conference earlier in the year. And at that conference, they talked about a new drug that's coming out, which impacts on our neurotransmitters and is thought to be a game changer with hot flushes. It has no side effects. It's been licensed in America now for about 3 years, and they've seen really positive outcomes. And that's due to be launched here in the UK either the end of this year or beginning of next year. So again, you can have all of these, you'll have all of these slides on the recording. It's something that you can Google, you can see when it's released. I suspect there may well be press coverage on it anyway, but that's certainly something to bear in mind if you think that might be helpful for your scenario. And then I've just put a link there, and that's just to sort of the non-HRT alternatives and the recommendations on it. Again, a really useful tool if you're talking to your GP. So just think about lifestyle changes. You will probably get to know what stimulates your hot flushes. We know that caffeine, obviously alcohol, hot and spicy foods, and obviously being busy can impact. So it's not going to be dangerous. It's not going to cause any issue if it does bring on the hot flushes. But if you choose to avoid them at certain times, then clearly just being aware of it can be helpful. Wearing really light layers and lots of layers can be useful because, as I described, you may go from being really, really hot to really, really cold, and being able to layer up and down as needed can be helpful. Thinking about the fabric that you either sleep in or wear, obviously the natural ones can be much better for maintaining body temperature than the more artificial ones. And I did share with my group this afternoon that since I've sort of headed towards perimenopause, I find when I walk into a clothes shop now, if I look at something that I quite like the look of, the first thing I do is feel the material. And subconsciously, if it's that artificial polyester silky stuff, automatically walk away from it. So I think it's just being mindful that actually, what are your bed sheets made of, and is it worth thinking about using something different. I have had a lot of feedback that those that use pure silk pillowcases and sheets find them really helpful. So again, that's just another tip that I've heard from the groups that we've worked with. If you have significant night sweats, then sleeping on a towel can be really helpful. It's much quicker just to change a towel that you're lying on, have a pile next to the bed, rather than having to actually change a sheet or a duvet. Chillo pillows are available on Amazon. They are a pad that you put in between your pillow and your pillowcase, and they really go cold. You just snap them and then they become cooling. And basically the area that controls our core temperature is at the base of our brain. So cooling that area down obviously is going to help to regulate the core temperature of the body. Just as a little tip, you can buy them for animals, so dogs and cats, and those ones tend to be pluggable. So they don't have you can plug them in at the beginning of the evening and they'll last you through the whole of the night. The Chillo pillow ones that you crack, often people will buy 3 or 4 of them and have them next to the bed so that they can change them if they need to through the night. And obviously handheld fans, just pop them in your bag and then you've got them whenever you need them. So this is an area that I'm really interested in, and I feel it's really important because this is something where you can make a big difference to your bone health going forwards. So basically, when we go through a menopause, the rate at which our bone cells rejuvenate is less than the rate at which the bone cells drop off. So basically, our bone density becomes thinner, our bones are much more brittle. But there's quite a lot that you can do to minimize the risk of that happening. So generally in the UK, every single adult and child should be taking vitamin D through the winter months. So when we're getting less sunshine, absolutely, that's what the government's Department of Health recommend. However, when we're peri or postmenopausal, or indeed on chemotherapy, we should be taking vitamin D every single day. And in fact, during COVID, anyone who was on chemotherapy, and some of you may have been having treatment during that period, was sent prescriptions for vitamin D because we saw such an improvement in immune response to a diagnosis of COVID. But equally, really, it makes a big difference on our bone density. The GPs that I work with have done lots of different sort of blood tests on people who have got low vitamin D, and the vitamin D that they see increases the concentration within the blood the quickest and sustains it is the Deluxe spray, which you can just buy over the counter. What's really important alongside vitamin D is your calcium intake. Now, calcium, you clearly can take a calcium tablet, but it's much better absorbed from your food and your diet. So the recommendation is around 7 portions of calcium a day. And on the next slide, I will be giving you a link to a really good dietetic sheet where it shows you how much calcium is in an array of foods, because it's not just in dairy, you can have it in fresh fruit and vegetables. So it tells you how much calcium is in each of those foodstuffs. One of the most important things is thinking about your exercise, and that needs to be weight bearing. So to make sure we're strengthening our lower limbs and lower back, a good old pound out walk, or if you're a runner, that's great, or resistance training is brilliant. what we need to be mindful of is our upper skeletal area, so hands, arms, upper back. The recommendation there is wearing a weighted rucksack from time to time. So if you normally go and do your shopping and you have it in a carry bag, maybe think about taking a rucksack, popping your shopping in there over both shoulders, and that just pulls the weight and resistance through the upper spine. One of the areas that's most at risk of breaking as we get older is our arms and wrists. So what the physios recommend for that is regular wall press ups. So literally every time you pop the kettle on for a cup of tea, put your hands flat against a wall and really push resistance through onto that wall, so you can feel the pressure going right the way up the lower arm and the upper arm. 3 or 4 minutes a day probably would be enough to just make sure that we're agitating those bone cells within the upper limbs. I've also put a little link in there, just which you can look into if you wish to, but there's been quite a lot of evidence and research now published around the benefits of fairly high impact exercise on cancer recurrence. So I'll send that out. If you want to read it, you can. You don't have to, but the recommendation is around 30 minutes, 5 times a week of fairly high impact activity. I mean, that could be digging the flower beds, it could be mowing the lawn, doing your hoovering. All of that would count towards exercise. So probably activity is a better way of describing it. And then the other thing just to mention is, I think if you have a family history or you're known to be slightly osteopenic, so that's the pre-condition to osteoporosis, then very definitely speak to your GP. And the nice guidance is that you should have a DEXA scan as a baseline and then go on to have regular DEXA scans. If your baseline is normal, probably every 5 years. If it shows any changes, you probably ought to be having a DEXA scan every 2 years. Okay, so that's the leaflet that the link will take you to, so you can just see it lists all the foodstuffs and the amounts that you need to be consuming to get your levels of calcium each day. So moving on to heart health, estrogen helps to keep, again, the equilibrium between the absorption of good cholesterol and bad cholesterol. Again, I would encourage you, if you are peri or postmenopausal, speaking to your GP to have regular cholesterol levels. If they're normal, probably then once every other year. If they're slightly high, then probably every 6 months. The things that you can do just to minimize the risk of that is reducing your salt intake. Obviously, that increases blood pressure, as would a high cholesterol level. Certainly stopping smoking, and that will have an impact on your bone health as well. We know in smokers their bone density tends to be less. Again, thinking about your diet, 5 to 10 portions of fruit and veg a day. That feels like I'm a huge vegetable fan, but even for me, 10 vegetables seems a huge amount. But I think look at your consumption over a week. If you're doing that 5 out of 7 days, or close to that 5 out of 7 days, then that's probably good enough. And then I've just listed there, all of the things we know about diet, thinking about the high fiber, high protein. Just look at your fat intake and which types of fats you're consuming. Go more for the olive oils and the omega-3s. Again, I've mentioned exercise. And then Caroline Garrett is an exercise specialist who works at Maggie's in London, has just written a book about returning to exercise after a cancer diagnosis. I haven't read it yet, but I've had lots of positive reviews, so I always just put it in so that it's an opportunity if it was something you wanted to have a look at. So now moving on to low mood. And again, the figures I think are astounding. Almost 70% of people peri and postmenopausal will have a diagnosable change in mood. And that's without a cancer diagnosis. We know 40% of people who have a cancer diagnosis will have some form of depression or PTSD. So again, you can see how you've got two things coming together that potentially are going to impact on those levels of mood. And it's all about how the estrogen impacts on the neurotransmitters. I'm not going to go into too much detail there, but what we know is the serotonin can make a big difference to how our brains are actually functioning, and therefore how we manage with stress and anxiety in our everyday life. I mentioned brain fog again. I've got lots of people who've been on chemo who haven't gone through a menopause who describe the chemo brain, and likewise people who don't have a cancer diagnosis go through menopause and notice this brain fog. So cognitive impairment is huge, and it's something that, again, I think is overlooked. You finish your treatment, you look well, you're back into the workplace, you're back running the home, and all of a sudden, you can't quite function how you were before, but no one actually gets that who's around you, who understands actually what the physiological changes are as a result of your menopause and treatment. So for low mood, we know if you can take HRT, low to moderate mood can help or be helped with HRT. And then, as I mentioned earlier, the SSRI, so the antidepressants, also can be helpful. But I think I always feel quite passionate that not the most important thing, but the equal to those antidepressants is thinking about what you can do for yourself. So we know when our sort of relaxation, enjoyment part of the brain is switched on, it suppresses our depressive, low mood part of the brain, and the two can't function together. So if there's anything that you find that gives you just a little bit of headspace, then that is not a luxury. It is a way of helping to rebalance those neurotransmitters in the brain. So, if you're someone who enjoys walking, gardening, the relaxation, mindfulness, all of those things are really, really important. And as I say, you giving yourself permission that is part of your recovery and part of your health and well-being. And again, these sorts of groups, the psychoeducational groups where you're learning about how your body's functioning and what's happening to it, can obviously have a big impact on just understanding the changes that you might be experiencing. So I've put a few bits and pieces there around brain fog. Obviously, we need to think about our sugar intake. The brain is an organ like anything else in the body, and therefore we need to keep it active. Again, focusing on diet. We know omega-3 is brilliant for brain cells, so certainly think about including that in the diet. Just being aware that this is going to happen, or it may happen, and therefore what can you do to make it less impactful? Thinking about lists. I know now if I don't write something down, there's no way I'm going to remember it. So I'm just having to be much more organized about, making sure I've got everything down on paper so I remember. And then just thinking about sleep. Melatonin, GPs can prescribe now for sleep for a maximum of 12 weeks, but sometimes that can just rebalance the way in which the brain's functioning. But also thinking about your sleep hygiene. It's very basic things, same time to bed, same time getting up, no screens before bedtime, no TVs or screens in the bedroom, and just keeping that very regulated, ongoing. So now just moving on to the pelvic changes. So we've got a little bit of a diagram here that just shows how the cells look. So the slide on the left is clearly a very healthy lining to the vagina. You've got the changes in the surface. You can see the cells are quite significantly deep, and then here, when we've gone through the menopause, the lining becomes very smooth, it becomes much thinner, and the cells are less elastic. So all of that can lead to sort of vaginal dryness, painful intercourse. And one of the things I think is always important to point out that it's not just about intimacy and intercourse. I had a girl I worked with who had horses, and her vaginal changes and dryness was so significant she wasn't able to ride a horse. So we managed to give her some very basic information which absolutely revolutionized her experience, and she was then able to get back onto the horse, which was wonderful. So but equally, the cells that line the bladder can also be affected, and that can result in recurrent infections. Again, if you're more susceptible to cystitis, you might get more recurrence of that going forwards, but also the urgency, frequency, and sometimes prolapse. So what can we be doing about this? I think just treating the genital area as you would do your hands and your face. We moisturize, we use hand cream. So just thinking about using very gentle emollients, gentle washing. For intercourse, we can think about using lubricants, and the two that we tend to recommend are silk and yes. Unfortunately, silk at the moment, there's a national shortage supply. I'm told it is being resolved, but at the moment, yes tends to be the one that is available. You can buy it over the counter. It's quite expensive, but your GPs can prescribe it. So I'm always happy to have a conversation with your GP if they're a bit resistant, because occasionally they'll say, well, you can buy it over the counter, so it's not coming out of my budget. But I think if you've been through a cancer diagnosis, then, you know, the reason you get free prescriptions is because you're likely to need lots more intervention going forwards. And the best thing for intercourse is to use an oil-based and a water-based, because then you get sort of a better glide between the two. So medical intervention, again, you can use local estrogen. So even if you're someone who doesn't want to take HRT or can't, then using a local estrogen in the vagina and around the vulval area can make a massive difference to the symptoms, and it will also impact on the bladder and cystitis as well. So if someone's got horrendous bladder issues, then using the topical estrogens potentially make a massive difference. And the dose of topical estrogens is really low. You can use topical estrogens for a year, and it's equivalent to taking one HRT tablet. So very, very small risk. Right, so just going to touch a little bit on, and I keep meaning to change the title of this slide. It's not sexual dysfunction, it's sexual change of function, because I think there can be, again, this real combination of, if you've had significant treatment, you've got hair loss, your libido's low because your testosterone is impacted, clearly that's going to make a huge difference on your desire and your ability for arousal. What we often find is that can then lead into relationship and intimacy issues, because intimacy is not necessarily penetration. Intimacy is holding hands, it's about sitting next to someone on the sofa whilst you're watching a film together. But often, if there's a breakdown in communication, and if your body is not responding to touch how maybe it did previously, then you can just see there's an awful lot of elements that may be coming together there to break down that communication around what's important for both of you. As I say, that doesn't have to be intercourse, that it can just be sitting holding hands, and that doesn't need to lead on to anything else, but keeping that connection is so important. So for sort of decreased libido, again, HRT can be helpful, the topical estrogens, but also testosterone. Again, it's not licensed for low libido in women, but is recommended by the British Menopause Society, with whom we work. And there's a very lovely patient leaflet which enables you to go and have a conversation with, again, your GP or hematologist around the benefits and the safety of using testosterone if you finding that libido is an issue for you. So again, the lubricants we've already mentioned. Psychosexual therapy, that sounds a bit heavy. I see a lot of couples, and I wouldn't say it's psychosexual therapy. It's around actually what's important for the two of you. Where do you both want to get to? Explaining to the partner, male or female, actually, this is the physiological changes that are happening, and that's why maybe when you touch, the body isn't responding as you have seen previously. It doesn't mean there's any lack of emotion there. It's just purely related to the hormonal changes. And one thing that we always say is anything that increases blood supply and flow to any part of the body can be really helpful. So just thinking about gentle massage, possible vibration if that feels appropriate, but all of those things can be helpful in increasing the blood supply to the area. So my last slide, again, it was really just to put a little bit of sort of context into this, and the fact that if you are thrown into a treatment-induced menopause, it's going to be far more intense and impactful than a natural menopause. And often that's, again, not understood, but basically you don't have a slow decline in your hormones. Basically they fall off really quickly. Support and help is really here, and it's really important, I think, that you're able to access that. It's absolutely fine to talk about this. One of the things that I often hear from people is, well, I should be really grateful because I've had all this amazing treatment, and should I be complaining about the fact that I can't ride my bike because I'm so uncomfortable? But actually, for me, the reason you have treatment is to attain a good life and a quality of life going forward. So it's absolutely important to talk about it. And as I've alluded to, as we've gone through, I'm always very happy to have a conversation with your oncologist or GP if there's any resistance to any of the things we've spoken about today. And just, I don't know how many have actually joined us on the call now. I think there's almost 20 people here. So, you're not alone. There's a real interest and appetite to learn and to understand how you can sort of take a little bit of control over these areas that you can have control over. So I will just stop sharing my screen now and just open up to see with Catherine whether there's any questions that we've had in the chat.
Thank you very much, Lisa. A very interesting talk. We did have one person had put in a question earlier on. I think you might have covered this slightly. They just said they have had a chemically induced menopause after a transplant in 2011. One thing being flagged for them is the effect on heart health, which is perhaps a late effect that we're still learning about. Also,
I was just going to say absolutely, and I think hopefully your team have been very proactive in monitoring that, because I think those are the important things. It's clearly optimizing what you can do, but also then monitoring and keeping a close eye on how the heart health is going forwards.
Thanks, Lisa. And someone else had just mentioned being interested in seeing the leaflet on testosterone. So if you have any kind of resources or whatnot you want to either send me, or you can send them around afterwards, that's absolutely fine.
Yeah, I will do that. I will send that on with the slides to you, Catherine, and then you can circulate it round to everybody.
Perfect. I'm just going to give one more opportunity. If anyone has any questions they want to pop in the chat box or pop in the comments section on Facebook, you can do that as well. If not, I'm going to share a little bit about just other things that can support you. So I think you would agree, Lisa, that if you're going through changes in your health as a woman, it can have quite a big impact on your self-esteem and your confidence as well. I know you do quite a lot of work at the Maggie centres around that. Did you want to share anything about the workshops that you do just so that people know about
Yeah.
what's available?
Yeah, I'm very happy to. So we do, so our menopause workshops are virtual, so they can always be joined, as are our CBT, so for hot flushes. So if any of you are experiencing hot flushes and that's something that feels like it might be an option, it's a two-hour session a week apart, via Zoom, and that's run by our clinical psychologists, so that's certainly something you could think about. We also do something called Aware Now course, which is for people as they're coming out of the end of treatment in that transition period, because I think, you know, when you're going through treatment, you're very much on a regular basis seeing your healthcare professionals, and it's about how do you adapt to that new normal after treatment, either going back into workplace, living with uncertainty. So that, I think, is another big area. And one area that particularly in Cambridge we're focusing on is families. One of the things that was really evident to me was the number of people that would walk through our door and say, I've just had this diagnosis. How do I go and tell my children, be them 5 or 15? So again, we do a lot in the centre around that sort of support, but equally, my art therapist who's trained in working with children and teenagers is able to do virtual work. And she does a lot. She does all of the stages, from people with a curative disease to those who are non-curative, and she does bereavement work after with the children as well. So there's that full pathway covered with continuity for the children.
Perfect. Thanks, Lisa. We just have another question in the chat box there. Is there a limit to how long you can take HRT, or an age limit, whilst having ongoing chemotherapy treatment?
No, so the only thing we say is the risks of taking HRT are only really from above the age of 60. So you are really very safe to take HRT up until the age of 60, unless you've got any of the risk factors, which your GP should be able to talk through with you. But then over the age of 60, you then have an increased risk because you're taking estrogen longer than your body would normally have it. But equally, I think depending on how you navigate menopause, there is a discussion around, again, risk benefit. So I've worked with some girls who have been suicidal when their estrogen drops off, their mood has been so low, and therefore their risk of taking HRT for life is far less than the impact that their low mood may have on them from a risk perspective. So again, it's very individual. It's about that discussion, and again, I'm happy to have that with any of you individually if that's something that would feel helpful.
Thank you, Lisa. I don't believe we've got any more questions, but we will be able to keep an eye on them as they come in still. Thank you very much. I think that is incredibly informative. Lots of information in that talk that is certainly new to me, and probably a lot of kind of tips and tricks in there for people to be aware of. We will be following on from this webinar with a support group, and Lisa is very kindly joining us for that as well. So that will be more peer support. We'll have more opportunity for questions in relation to women's health, menopause, but also just general support, women to women. We're going to be joined by Look Good, Feel Better in that support group as well. So they're going to do a little bit of a talk about what support they can offer. That will be focusing on building a little bit of self-confidence, building self-esteem, particularly if you're just finished treatment, or generally if you're struggling with your appearance or your confidence as part of your diagnosis. I will just share my screen slightly for a few minutes just to give you an example of the type of support that they can offer. Little things that you can try and do. I know Lisa had mentioned in her slides about kind of mindfulness, relaxation techniques. We do tend to kind of have speakers every now and then in some of our support groups that will offer you a little bit of insight into those techniques. We will be having a wellbeing webinar later on this year that we will be giving you a little bit of an opportunity to look at those in a bit more detail. But I will share just now just something that was sent to me by Look Good Feel Better that can give you an idea of how you can add this into your daily routine, or you can try it once, and if it's not for you, you can look into whatever might work a little bit better for you. And if you do have any questions, Lisa's still with us until the end of this group, so do feel free to pop in any questions if you've just thought of something afterwards, and we can come to it then.
Hi, I'm Anastasia, and I'm going to be showing you and Eva today how your daily skincare routine can help you to look good and feel better at the same time. So Eva, I'm going to upgrade your skincare routine. I'm going to shift slightly the focus on just a way of applying a product to actually you really taking some control over the way that you do it. So not so much about the product really, shifting the intention onto you. I'm going to use a balm, but you can use a cleansing milk, you can use a water, whatever it is that you prefer. I think that when the skin becomes dry, when it's been through some kind of trauma, it's often wonderful to put more oils onto the skin through cleansers or cleansing balms or something a little bit more milky. So what I love to do is to start by, I'm going to have you take a deep breath, and I'm going to have the cleanser be applied not just onto your face, but to remember that our face is also attached to our neck. Now it may seem like a silly thing to say, but so many of us don't include this area that actually holds so much tension. So I've included the top of the shoulders, the neck. I'm going to go right over your lips, the nose, around the brows, over the forehead and back. And at the whole time I'm going to have you take some deep breaths.
That feels really lovely and relaxing. It's really relaxing.
Great, so we've probably used up about 20 seconds up until now. So let's do 10 of these. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Moving up to the jaw. 1, 2, 3, 4. I'm moving from the center out. 6, 7, 8, 9, 10. We're probably at about 45 seconds. And I'm going to go 10 circles around the eyes. 2, 3, 4, 5, 6, 7, 8, 9, 10. Probably at around 50 seconds, a few strokes over the forehead, all the way back down. We've got a lovely blood flow that's brought a flush to the surface of the skin.
So when you do it, it's lovely, and you're applying the right sort of amount of pressure and the right points. But if I do it, I'm in a different position from you. So I'm doing it to myself. My hand position would be different.
So if you were to take your thumb and these two fingers and turn them this way here,
This way with a thumbstick.
then you would be doing what I was doing. And now if you bring all of the palm of your hand and you grab that lovely trapezius and you give it a pull and a squeeze.
Okay.
Great. So let's have you do the one that we did here. If you put your hands in a prayer position, Eva, like this, and you go outward,
So
and
it's pushing up.
well, actually it's great that you did that, because what I'd like you to do is to push out to the ear.
Okay.
1.
And then 10 times.
Yeah. And why? Because we hold a lot of tension in the jaw. And if you do an upward movement, you actually miss that muscle where we hold it so tight. And then you're going to bring your hands from here, you're going to scoop them up, and you're going to come to the eyes, and you're going to do those nice 10 circles that go around the eyes. Instead of removing with a cotton wool pad, you can immerse a flannel or a washcloth into the sink or just under a running tap, and you can use that cloth, you wring it, and you put it directly onto the skin. Take another deep breath, and then that cloth will pick up your cleanser, and it will also pick up your makeup. Any contact we have with water always makes us feel better. I'm going to pop that over your face, and you're going to take a deep breath. And we're gently going to go wipe around the corners of the eyebrows, the nose, the lips. Now, what we're doing is, because we're naturally using something that's just a cloth, what it does is it picks up any loose, dead skin. I'm going to show you how to apply your moisturizer, and we're going to keep the same framework, 1 minute, and we're going to include the areas that maybe we would never have thought to include. When we use moisturizers, if we slightly shift the focus onto how we put them on again, it makes the biggest difference. We're going to take our deep breath again. Nice deep breath, and we're going to apply generously this moisturizer, not forgetting the lips. You would be amazed how much we forget these important parts that also need nourishment.
So that's just a little idea of something that you can try, adding that into your daily routine, and see if it gives you a little bit of relaxation. There's lots of different resources on the Look Good Feel Better website as well, videos that you can follow. There are ones for kind of hand and nail care, general kind of relaxation. If you are looking for more information on any kind of well-being and mindfulness tools that you can use, feel free to send me a follow-on email, because we will have resources that we have been given by some lovely guest speakers over the course of some of our support groups as well. I don't think we have any more questions. I'm just going to quickly double check here that there's not anything coming in from Facebook. No. So I think that's us for today. Thank you everyone for joining. Thank you especially to Lisa. It's always a pleasure to have you and to hear all about the work that you're doing. I'm just going to share for a few minutes some slides about how Leukaemia Care can support you, what we have available. Lisa, you're welcome to drop off if you are on a time frame, but as always, it was lovely to have you, and we'll look forward to having you at the support group as well. I know that we're going to send out your information to people afterwards, so as Lisa said, she's happy for you to contact her if you'd like to follow up individually for any advice. That's very kind of you to offer that support to people as well.
No problems. Lovely to be here, and thank you for welcoming me, Catherine. I'll see you soon.
Thank you very much, Lisa.
Bye.
I'm just going to share my screen, and I will let you know a little bit about what support we have available. Hopefully this will pop up okay on your screen. Sometimes it goes a little bit funny when I try and share this. So just an overview, how can Leukaemia Care support you? We have lots of information sources available. You can find information about all of these on our website. Our webinars are recorded events. We do have some of our past webinars on our YouTube channel, and you can find information about upcoming webinars on our website as well. We have newsletters and our Leukaemia Matters magazine, where we have updates, normally updates in research or new treatments as well are in there as well. Podcasts, if you prefer listening or watching things. Social media, we have closed Facebook groups you'll be able to find us under. If you have any problems finding us, you can send us an email and we'll divert you from there. Support services, you can call our helpline. That's available Monday to Friday. We've also got a WhatsApp if you prefer to just text us. Virtual support groups, all of our national support groups take place online. These tend to be disease specific or focusing on a certain topic. We also have some local support groups that take place online, or there might be some in-person support groups available in your area as well. All of that information you can find on our website. We have welfare advice if you're looking for information about benefits or what you might be entitled to. Our advocacy team, they can support you with a range of issues that you might be having, whether it's problems with your care or you're looking for a bit of advice on insurances, things like that. Online forums, if you want to share your experience, ask some questions, and our buddy scheme can match you up with someone one-to-one. Our buddy volunteers are wonderful and a really great support if you would just like to have a bit of a chat with someone on your own. Our counselling fund is also available. This covers up to 6 sessions with a registered counsellor. I'll leave this up for a couple of minutes in case anyone wants to take a note of the helpline number or our email address. From there, we can direct you to any of the teams within Leukaemia Care for more specific support. Just a little bit about our counselling fund. If you want to find more information on that, you can find that on our website, and you can also apply there as well. Patient information booklets, these are really helpful if you are newly diagnosed or you're trying to explain your diagnosis to your family and friends. It can be quite helpful to just order some free booklets and hand them out to people. Quite a lot of people tend to find that quite useful. You can download them as a PDF document, or you can get some hard copies in certain booklets as well. If you're interested in becoming a buddy or receiving a buddy, you can let us know. Again, you can do that through calling the helpline, or you can find a little bit more information on our website. If you want to contact our advocacy team, again, I'll leave that up for a couple of minutes just in case anyone wants to take note of the advocacy email address. Or again, give us a call on the helpline and we can direct your query to the advocacy team directly. There's a range of ways that our welfare and advocacy team can support you, so please don't hesitate to reach out to us if you're looking for a little bit of support. Just a few ideas for fundraising. You can do many things. You could start with a bake sale, or it could be something like an online quiz, or if you really want to, you can run a marathon. Whatever you're capable of doing, or your family or friends might want to do, we would be very appreciative. If you're looking for any more information, we do have some fundraising ideas on our website, or you can contact our fundraising team directly on the email below there as well. We're going to follow up, as I said, from this webinar with a support group. We will again be joined by Lisa, and we'll be joined by Amanda from Look Good, Feel Better. That'll be more of a kind of peer support session. We'll generally be discussing the topics that were covered today. And if anyone has any questions that they want to put to the group for that. That will be taking place on Thursday, the 14th of September. It will be online via Zoom, and that will be taking place at 5:30. So if you're able to and you'd like to join us, you can find information about that in the follow-up email or online on our website. So thank you everyone for joining. I hope you have found this very informative, and we'll look forward to hopefully seeing you at the support group afterwards. Take care, everyone.